And there we go. Good morning, everybody. My name is Mark Driscoll. I am the Ohio AAP project manager for the Preventive Health Program. We're excited about our presentation today. I just have a few little housekeeping things to go through, and then we'll get into the rest of the presentation. If you don't mind flipping the slide, Dr. Halloran. So just a few things from me. As the presentation is going, please make sure that you're muted and stay muted. We do have the chat box being monitored. If you have questions throughout the presentation, we will ask those of our presenter. The slides today and this session are being recorded, so I will send those out afterward, as well as information about how to receive your CME credit for this presentation. And you can flip again. And then our presentation today is screening for maternal depression, rationale, and best practices. And then one more slide. Liza Halloran, faculty for this educational activity, has no relevant financial relationships with ineligible companies to disclose. And Dr. Eliza Halloran is a clinical psychologist teaching in the family medicine residency program at Mercy Health in Toledo. Previously, she has been on the faculty at the University of Toledo Psychiatry Residency Program and had a private practice and worked in juvenile justice. She has focused on helping children and families throughout her career. And without further ado, I'll let you take it away, Dr. Halloran.
All right, thank you very much, Mark. Okay, so today we're talking about maternal depression. So we're going to start with a little pre-test with a few questions. And then by the end of the time, we should be able to answer these easily, although you still might have some good guesses to start. So the first question pre-test would be about what percentage of women are experiencing postpartum depression or perinatal depression around the pregnancy and childbirth time. So we'll have some guesses. We'll be talking about that right off the bat. And what other things are associated in children with the mother's perinatal depression? Missed well child visits, missed immunization, discontinuing breastfeeding, poor scores on cognition, language, behavior, or all of the above. And we'll definitely be talking about the impact on children. And then the last thing we'll be talking about, well, we're talking about a lot of things, but the last question is asking about what is associated with screening for depression during pregnancy or following pregnancy, and what is associated with treatment. Does it have no impact, or are there significant decreases in depression and other functioning at different times? So that's just a little pre-test. The objectives today are we're going to be talking and discussing who is impacted by postpartum depression, which you might just think women, but we're going to talk about other people also impacted. What are the risk factors and the clinical features that we want to be attuned to because they raise concern? Why is screening for postpartum or perinatal depression so important, and how can we do that effectively? And then which treatments are helpful, and also just a little bit of discussion about, well, what are the barriers to care? So those are the objectives of today's presentation. So let's start out, like, who is affected? Obviously, it affects women. That's not a surprise. There's a wide range of estimates in the literature. It's kind of hard to pin down an exact number because every study will kind of come up with a different estimate of how many women are affected by this. So there's a wide range, anywhere from 20% to 6.5%. So we kind of take a lot of, generally in the research, they'll say 1 in 7 or 1 in 8, which is that 12.5 to 14%. So that first question, the 13% would probably be the best answer. Obviously it affects women, but there are equity issues. It affects women differentially. You can see this is PRAM's data. So in 1987, New Jersey started collecting data, and a lot of states are in the PRAMS data set. So this is based on the highest numbers of people in the PRAMS data set, but it's not all states. And actually, Ohio's not in that data set. But so for mostly across the country, we see these kind of rates. And again, you see this high range, right, from the lowest of white non-Hispanic to the highest of more indigenous people. You see a wide range here. And in Ohio, the Ohio data is the Ohio Pregnancy Assessment Survey. And in Ohio, it's about 16% from the 2021 data. So lots of ranges, and this might be a little bit on the low side if Ohio is at the 16%. But who else does it differentially impact? We see the equity issues with race and ethnicity, but we also see equity issues with postpartum depression impacting younger women. Less than 19 has the highest rate here. Less educated women, less than a 12th grade education has the highest rate here. Women with, low in support if they're not married, they don't have so, obviously there are exceptions. You can be not married and still have a lot of support from your partner. But in general, not married gives a higher range of postpartum depression. And then meeting the eligibility for WIC, so lower in financial resources, also higher rates of postpartum depression. So you see all sorts of equity issues in who is impacted. But it's not only the women who are impacted. Fathers also can wind up with depression around the perinatal period, with a whole over 8% estimation for the fathers as well. And I'm sure those ranges also, every study will have a slightly different rate, but these are our best estimates. So the maternal depression actually puts the mother at risk for kind of chronic depressive disorders over time. So it's very important that we get the treatment. It puts the father at risk also for having depression during this time. And then the infants and children are at risk from this impacting the parent, the mom, especially having difficulty during this crucial time. So in the early months, there you will see differences in children not being put to sleep on their back, not continuing breastfeeding as much, more crying. The moms with postpartum depression are twice as likely to smoke after delivery. The children do not get as much of the preventative services that they would need, and less likely to use safety devices. So these would be, in the earlier time, but we have data over time that then goes into more of the problems over time, with language development being delayed, having risks of behavioral and emotional problems, and even an increased risk of ADHD. So there have been numerous studies about the association of maternal depression and children. And so there was a meta-analysis, which is a study of all the studies, showing how significantly children are impacted by maternal perinatal depression. And of course, these are associations. We cannot ever say it causes it, but we need to, make sure we're paying attention to these things and how can we be helpful. So you see how many studies have been done for each of these domains, which most of the studies being in the social emotional domain. And the majority of these findings are on the younger children, but not all of them. There are some studies that continue up to age 18. And so you see the impact on children, on older children and teens. And particularly the social emotional domain, you see the behavioral problems, peer problems, difficulty regulating emotions, and those problems kind of carry through to a lot of children not thriving. There's also the domain of the cognitive domain, where children are not doing as well in school and on academic tasks and achievement. The language delays, which is probably related to the academic achievement as well. And then fewer studies on motor issues, motor coordination, fine motor skills, and adaptability. So the majority of these studies were in the social, emotional, and cognitive range, but it did not, it's concerning how many studies have found this association between the maternal perinatal depression and how children are not thriving the way we would want them to be. So, how do we think about this? What is going on with these consequences to the children? Well, there seems to be kind of a negative spiral that gets started off in the early years with the maternal infant relationship and the attachment relationship being impacted. If you have a depressed mom, she's really struggling, right? We're going to talk about symptoms of depression, but there's a lot of shutting down and a lot of, um, sadness, and all of those behaviors that you see in depression are going to impact her ability to relate to and interact with the infant. So when you're having these impaired initial bonds, that that makes it very difficult on the child for the self-regulation and ability to soothe. And then the mom could easily become frustrated and even more negative towards herself. If the baby is, we had on the earlier slide, the baby cries more, she could easily go into thoughts, negative thinking patterns of, I'm not a very good mother, and my child's behavior is reflecting on that, and then fall into negative parenting practices where she's overly harsh rather than helping to build skills and not feeling confident about her parenting. There could be a lot of marital discord, and all of these things are really impacting the child, which ultimately leads to poor outcomes over time in the children's physical as well as psychological development. It is worth noting that when the mother's depression remits, that there are associated improvements in the child's behavior and other mental health symptoms. So, they're all associations, but there's definitely a lot of evidence saying we need to help families and help moms through this time for the mom's sake as well as for the child and family's sake. And particularly with the negative parenting practices, what has come out in the research is that the children are much more likely to be exposed to psychological types of abuse in their negative parenting practices. So the other thing we want to make sure that we're addressing is a way of interrupting this cycle, this spiral down, because then if we're having the negative parenting practices that may include psychological abuse, we're setting up that child for then having mood problems, anxiety problems, traumatic kind of reactions to things, and then we're going to have a real negative cycle um, through the generations, and we want to be interrupting those cycles rather than having more problems with that. Okay, so what are the risk factors that we have that increase the likelihood of maternal postpartum depression? There are multiple obstetric risk factors. You see the long list here, kind of any of the problematic things, including the baby being either preterm or a low birth infant. So these are all important to pay attention to. We see psychological risk factor, and especially this history of depression or history of anxiety. That's something that we would want to definitely pay attention to, as well as, any kind of negative attitude towards the baby. We have social factors. Lack of social support is definitely, um, we want to pay attention to that, and if they're willing to disclose any of the more serious problems with a partner that we would want to address. Unfortunately, a lot of women aren't able to disclose that. Um, and then social factors, smoking during pregnancy is a risk factor as well. And that kind of goes into the lifestyles where, of course, eating habits, physical activity, and the sleep are risk factors for postpartum depression. And sleep, of course, everybody who's ever had an infant knows that sleep is a precious resource. So it's kind of hard to figure out, the role of sleep in depression versus just sleep deprivation from being, the parent of a newborn, which is you don't get a lot of sleep. So that leads to the next slide, which was the clinical features of the depression. How we typically make this diagnosis is you have to have one of these first two symptoms, depressed mood or loss of interest or pleasure. That's one of these is kind of the hallmark of depression. And for the perinatal or postpartum depression, you would have it within, these symptoms within 4 weeks of delivery or during the pregnancy. But as I was mentioning, the sleep, the physical symptoms of depression, like sleep and appetite and weight changes and exhaustion, loss of energy, these are a little bit harder to assess during the perinatal stage, because everything's just, turned upside down. So it is very important, though, to pay attention to more the cognitive parts of depression, this feeling worthlessness or guilt, um, recurrent thoughts of death. These are more the cognitive symptoms of depression. And those would be very important to pay attention to, especially worthlessness or guilt. Many moms on becoming a mom feel a great sense of meaning and purpose. And so to feel worthless or guilt would definitely stand out as a symptom of depression. We definitely need to pay attention to these increased risks and symptoms, because in the first year following birth, the mother's suicidal risk was the highest, and it was 7 times as high when there was the depression. And this risk did persist over time, but it's that first year that is really where we want to be very careful that we're attending to women and how are they doing during this time. So that leads us to the importance of screening for the postpartum depression. As I said, there is at least 1 in 7 or 1 in 8 are reporting signs and symptoms of postpartum depression, but it's believed that there's a significant amount that is not being recognized. The researchers have a hard time coming up with an exact number about that, but there is agreement that a significant amount goes unrecognized, and that we do need to do a better job of finding identifying the women who are struggling with perinatal depression. When it is recognized and treated, most cases are going to resolve with treatment, but there are still some cases where within the first year, 24% are still struggling, and even after 2 years, 13% of those diagnosed are still struggling. So we need to pay attention to all these women and help them so they can help the whole family, the child and the partner. This also has a huge economic burden for society, with an estimated $14 billion being, costing society for the 2017 birth cohort for 5 years. So that'd be 2017 to 2022. And this estimate is actually for all of the, today I'm specifically talking about perinatal depression, but when they do the economic costs, they lump in the perinatal mood as well as anxiety disorders, because some people do have anxiety following the birth of the child that is getting in the way of their ability to function. Perinatal depression is more common, but anxiety can also happen. Okay, so then let's go back to screening. So screening is a way for for the clinicians and providers to be able to recognize when the mother is struggling at a level that is that really needs much more attention. I remember becoming a parent. I think every parent feels like they're struggling. I had every resource in the world, and I still found it very overwhelming and difficult. But it's a different level of struggling when you're answering questions on a screening in the positive way that are going to put you show that you're at risk for the depression or have the depression. And really, the screening is very important because once you can identify it, it's very helpful in just naming it. I don't know if many of you have heard of the name it to tame it kind of idea. Whereas if you just name something, it helps you be able to focus on, oh, I need to address that. So the screening can really help with identification and name it to tame it. So when women are screened, just the screening alone results in improved outcomes. It improves the depression rate at 9 months just by asking these questions. Because most likely, because when you ask these questions and you have, oh, this is a problem, then the woman on her own will be like, oh, I need to pay attention to this. So the screening alone will help the moms improve their depression at 9 months. Again, not everybody, but a significant amount that they can find this in the research. I'm gonna show you the Edinburgh screening tool because I think it's a good one to use, and most people prefer that tool over other, like the PHQ-9, which is the Patient Health Questionnaire 9 Symptoms of Depression. When we look at the research, there are no harms associated with screening. It doesn't cause more trouble to ask about these questions. And then once they're screened and they can be identified and referred to treatment, well, then the next question is, does treatment result in improved health outcomes? And yes, it definitely does. Any treatment can help with the depression and looking at outcomes over 12 months, but cognitive behavioral therapy is a little bit superior to medication. And this, of course, is always individualized, but the research will show that cognitive behavioral therapy has strong data to support it. Are there any harms associated with treatment? There's very low incident of harm with meds. For the most part, medication is safe. There are no harms associated with therapy, cognitive behavioral treatment, or interpersonal therapy for depression. So screening, there's a lot of evidence that screening for depression can be very helpful to women and their families. Okay, so let me talk a little bit about how we want to screen. So the first step would be these two quick questions. These are the two questions from the PHQ-2. Because with depression, like I showed on the other slide, you always have one of these two things, either little interest or pleasure in doing things or feeling down, depressed, or hopeless. So if somebody answers a score of 2 total for these two questions combined, so a 1 and a 1 or a 2 and a 0 or anything higher than that, you would then want to give a longer questionnaire. You can use the PHQ, and that can be used for any caregiver, but the Edinburgh is used for the birth mother, and that is preferred, and I'm going to show you the questions from that. And this is what I was kind of saying earlier about when I had the symptoms of depression. I said, pay attention to kind of the cognitive symptoms of depression. And you'll see on this Edinburgh, it's really more about the cognitive and the emotional symptoms of depression. This questionnaire does not ask about the physical parts of depression as well, because it's so convoluted with being exhausted from um, caring for and going through the pregnancy and caring for an infant. So this is much more about how do you see the world? How do you perceive the world? Is it still enjoyable? Blame is a cognitive thing. And then the associated negative, um, feeling sad or miserable or unhappy because you're having kind of negative cognitive thinking patterns. So this is at Edinburgh. It is free. You can find it online. What they ask is that when you use it, you always cite this source here. So it is a free online tool, and it's for the birth mother. So that needs to you need to limit it to the birth mother. If you have somebody else caring for the infant, then you can use the PHQ-9. Okay. So we definitely want to screen for depression, and be paying attention to how is the mother doing following the birth of the baby. But this can be done even before the baby is here. It is helpful to screen for depressive symptoms during pregnancy and talk about um, any risk for depression before the delivery. If somebody has a history of depression, that would be very important to discuss with the mom to be. How is she going to take care of herself? How is she going to make sure that she's has the support and she can get sleep, and just kind of brainstorming a little bit to prevent anything. How can she rally her, support system so that she knows who to call on if things um, are more of the emotional struggle and going to depression, and because an individual will know, oh, when I get depressed, this is what happens for me. I need to pay attention to that particular symptom. So, providing information and education and discussion about this, teaching women and their partners about this beforehand, that helps with people actually going and seeking treatment if these symptoms were to come up. It doesn't make them have it, it just lets them um, make a little plan so that they'll be able to seek treatment and get the help that they need. It also takes the stigma away, because if you're doing this with everybody, it's universal education. Everybody should be aware of, oh, we're all at risk, and what's our plan if this happens. And women are at risk because there's a huge no woman is like of course, nobody wants this, but there's so much hormonally going on for women that it complicates things. There's lots of risk factors from the, you know, uneducated or lower education and lower age and those things. But there's a lot of hormonal stuff going that nobody can. It's just part of childbirth. Um, so there's the risk. So we want to prevent it by having these discussions, making sure the discussions are early enough so that people will go seek treatment with, knowing that this they're not to blame about it. Um, and then we screen for it. And then if we give the support for breastfeeding, that can be a very helpful thing too for the mom, because especially if she's interested in breastfeeding and wants to do it and then is struggling with it, again, normalizing that and helping the mom know that there's a reason we have breastfeeding support groups, because it's hard and a lot of people need that support to get through it. We also, if we can help moms with understanding child development and just typical parenting struggles and promoting that early bonding, those things can also help prevent perinatal depression or postpartum depression. And then of course, helping people work on some sort of sleep plan so that they're not continuously sleep deprived and struggling. So when we do the education and screening, I just want to reinforce that it's not like you just do it once and you're done, because things change. Things change a lot, sometimes hourly when you're caring for an infant. So we need to have, ongoing conversations, and probably a screening during pregnancy as well as a screening after pregnancy, and then maybe a screening another 6 months post-birth. The more you can just keep the conversation going, the better. It is also important to assess substance use, because that would likely impact who you would send somebody to for treatment. If substance use is also going on that's problematic, then the treatment would be a little bit more complicated, and you would want to make sure that person got to the right um, therapy provider or treatment. Um, because if the mom trusts you enough to disclose substance use, we want to make sure she gets to someone who's going to be appropriately helping her. Okay, so the screening's positive. We need to do referrals, but also what can you do? What now? You have the person in front of you. What can you do to help them? First of all, you can let them know that you are here to help them. You can be empathic and supportive. It would be, it's very important. Remember where I was talking about the cognitive aspect of depression. We would want to be very careful with our words, because it would be easy for somebody who is depressed to feel like a bad mom and to feel like they're failing their baby somehow. So we wouldn't want to like rattle off all the ways that this is bad for their child and that the mom needs treatment. We don't want to like scare them into treatment. We want to make sure that we're just there to support them. I mean, we know that it can have negative impact on the baby and the child, but that's not what we say. We want to say, how can I help you? Your health is very important. Your baby wants, your baby needs you to be as healthy as you are. You can be kind of like the put your own oxygen mask on first before helping others analogy, emphasizing their importance, and how can we support you well in an empathic, compassionate way, and also normalizing this, that they're certainly not the only one. Like at least 13% are identified as having these kinds of struggles, and even the entry into parenthood is just really overwhelming for a lot of people. um, but that we see that they're answering these questions in a way that shows us that we need to pay attention and give them support and help. We want to be able to give them resources that they can walk out the door with, and this is a great little booklet that you can access online that helps people recognize it and feel okay, that it's not their fault. Depressed people often feel that they are to blame, they're excessively guilty. Um, so so any resources to help them feel that there is help out there and that they can get the help. If we rally the community resources for the family support, and we screen and offer education, then more patients will follow up on those resources when we're kind of providing all of the compassionate support and screening. Okay, so I want to show you some of the resources that we do have. There is the support would come in breastfeeding support groups, parenting support groups, and mental health kind of support groups. And so I'm going to talk about support, and then we'll talk a little bit about, bona fide treatment. So, but even if you're in treatment, it's good to have just the support also. So Ohio does have a breastfeeding hotline and support for breastfeeding. Cincinnati has a lot of support for breastfeeding, so that's good. If you're not in Cincinnati, and if you're somewhere else, there is the Leche League that has a website, and you can find support there. But Ohio has its own support statewide, which is great. We also have parenting resources. So there, and I assume everybody on the call is just widely spread through Ohio, but there are different local state parenting groups. There is something called centering parenting, which is a child health care system that really kind of focuses on early relational health. So that is a great, if there's one in your area, that is a great resource. Ohio has Triple P, which is a positive parenting program, and it's free and it's online. You go to the website and you can sign up, and it will it'll gear it towards the age of the child you have. And obviously, an infant, we're not disciplining, but it's really about developing the relationships, so that you understand child behavior, understand the importance of self-regulation, and helping the baby learn to self-soothe, and all these things. There's lots that can be done in the very early years to set up positive parenting. And then there's some Sparks videos through Mount Sinai, which are great videos that help. They're like 8 minutes long each, and they help the parent. They would help the mom know what to expect for each of the baby's well child visits. So every time you go in, they'll say the doctor should be covering these things, and you can ask questions. This would make, it's just more education to use the visit time very wisely. Make sure you get your questions answered, and just have a good basic understanding of the child's development and what the doctor's looking for. But they're just really well done videos. And when parents feel more sure of their ability to parent, they do better with that cognitive piece of the depression, because they're building skills, and then it's easier to say to themselves, I'm doing this, I have this. There's also, Mount Sinai also has a great caring for your newborn video that is also, it's on another screen, but I believe Mark is going to have a handout with all of these references, so that will be helpful. There's also support. So we talked about breastfeeding support, parenting support, and then the mental health kind of support. And there is a free confidential hotline for pregnant and new moms, both in English and in Spanish, the National Maternal Mental Health Hotline. So this is a fantastic resource for people across the country. There's also through NAMI, there are ways to access different support groups. And I don't know if people know, NAMI is the National Alliance for Mental Illness. It helps a lot of patients as well as family members with all sorts of mental health diagnoses. So they have their postpartum depression resources. And then this slide just has all of them, and I believe that will be what's your handout. Okay, so we have the support resources, which are helpful, but a lot of times we need the actual treatment for postpartum depression. And so if you do your screening and you have very low scores on the Edinburgh or the PHQ, you can just rescreen, but everybody should be get access to all these kind of support groups, or if they at least know about them. So with none to minimal depression, you're just going to rescreen. But when the scores go up a little bit to mild depression and on up, then we definitely want to refer for treatment. And so the cognitive behavioral therapy will help focus people definitely on that cognitive piece of depression where people fall into negative thinking patterns, blaming themselves, talking to themselves in a way that they would never ever talk to a friend the same way. Um, like, oh, I'm a bad mother. I can't do this. Whatever negative thoughts they're having. If a friend came to them and said, "I'm really struggling with my baby. I don't think I don't think I'm cut out to be a mother." Nobody would ever say, "Yeah, you're right. You're not cut out to be a mother." But then people say that to themselves. So working on that cognitive piece of the depression as well as the behavior piece, and the behavior piece would be like, what is your plan for sleep? What is your plan for eating? What is your plan for activity? What is your plan to get social support? And then the interpersonal therapy is also a validated therapy for depression. It focuses much more on relationships and how and your attachments to other people, and thinking of depression through that attachment lens, which can also be very helpful. In the mild depression, you might want to start an SSRI, or this is the talk for the non-physician group. So we would just say to the patient, talk to your doctor about possibly starting an SSRI and reassure them that they have been found to be safe, but the doctor would know more about that. Um, and then, this moderate also the CBT or interpersonal. And then we're getting into like, well, maybe we really want to have the meds on board. And when it's severe, the recommendation is to start with the meds first and then do the CBT after there's been some improvement. Because sometimes this can getting the medication on board could kind of jumpstart, um, and then patients can take advantage of what cognitive behavioral or interpersonal therapy has to offer. So sometimes you might need, when it's severe, start with meds. Um, Okay, but these treatments have been found to work. They are helpful. Most cases, like I said earlier, most cases resolve. There are those, it was 24% that, are still, the mom is still struggling after the first year, and 13% they're still struggling even after the second year. Um, but then that's just a more individualized approach that needs to happen with the therapist, the physician prescribing the meds, and the family. Okay. And then the last thing I wanted to talk about was how do we help overcome the barriers to women getting maternal mental health care? And there was a study that I found that interviewed women. And this was a study of women. They had actually embedded the mental health care in the doctor's office, which the women really, really appreciated having their own maternal mental health care in the child's physician's office. So, because it was so much more convenient, the moms felt that it was very, very proactive. Like, we're caring for the baby, but we need to check in with you because we know there are risks. They felt like that proactive approach was very helpful. Um, it also helped just with consistent access to care, because a lot of times mom will take their baby to the doctor, but then they won't go to the doctor themselves. Well, they got their care in the same place. Um, they also talked about how their own psychiatric symptoms made it hard to get care, because when you're depressed, it's hard to, sometimes you don't even do basic things like care for yourself by eating. So getting a higher level of care, making it to the doctor's office would be even harder when you're suffering from depression. The moms were aware of the stigma. They reported being afraid that if they went and told somebody about how much they were struggling, that Child Protective Services would come in. So these are some of the barriers, that the stigma, the fear of Child Protective Services, and depression being, like the one disease that the disease makes it impossible, not impossible, but very difficult for you to get the treatment. Like if you have cancer, you're not like, oh no, I don't want treatment for cancer. You're like, oh yeah, I want it. But when you have depression, you're like, no, like I can't do it. So depression is a very difficult disease that way, illness that way. The other thing that these women talked about that was interesting is that they really appreciated the clinicians who were able to help them see that their own health is linked to their children's well-being. So to do that in that supportive way, that they need to take care of themselves, for themselves, but also for their children. And again, not like it's a fine line, because you can't do it in a way that scares them, like, well, your kid's not going to be okay if you don't take care of it. But like, you are very valuable to your child. You are the only person that could be this person's mom. It's just impossible. This kid can't have any other mother than you. And so we need to help you, so that you can, get back to being who you are, and overcome the depression, so that the child can also thrive. So moms could appreciate that link being made, um, when it was done in this compassionate way. This is motherhood is a very stressful time. And so recognizing that this is such a stressful time, that many people are much more vulnerable for having depressions or substance use at this time, that kind of helps take away the stigma. It's not just them. And then the women in this group also talked about how parenting skills was very helpful to them, and it helped just kind of normalize the experience of being a mother. They had concerns about medications, and I think a lot of women do have concerns about taking medications, but that's where we need to refer them to their physician to discuss their concerns if they're having them. Okay. Yes.
Liza, this is Chris Bowling, kind of interjecting here. We had a question on this barriers to mental health care. Mariah Sharp put something in the chat box that I was going to have you address if you could, because it's a real challenge. Mariah says her coworker and she administer Edinburgh screenings in their OB-GYN office.
Great.
Oftentimes, I identify mothers with postpartum depression and offer in-office counseling with certified counselors. We also make external referrals, and a lot of time the mothers do not answer the calls from the referral location to schedule. We try to catch them in office to identify barriers such as transportation, childcare, etc., but still cannot get them to follow up with external counseling resources. Any recommendations? Our external locations sometimes call 3 times to attempt to schedule and have to re-refer at that point.
Wow. Yeah, that's okay. I'm glad she put the reality into this is really what they're dealing with. Anyway, but it's an external referral, but they offer inside in the clinic, I thought, in the beginning of what she said.
Correct.
So, I mean that, because they're not even taking advantage of the internal referral part, or they do that, but then when it gets time to take it to the external, they won't go. Am I understanding it right?
Mariah, do you want to unmute yourself and
Yeah.
explain that? I think she's still on the call with us here. Let's see. Oh,
Yeah,
yeah.
she might have had to Okay, well, so I mean, I guess I could just answer if you're offering in in the clinic, and if they're, I mean, if they don't take advantage of in the clinic, eh, that's, I think it just goes to like the stigma and um
Yeah,
how ineffective they feel. Actually, I think the thing that would be the most helpful is in that situation, if you could find some moms from your that have like graduated from whatever the services you provided, the moms who have already been through, whether it was just one session or a group or whatever, or the external thing, if you could have kind of like that peer advocate of like saying, yeah, I know a mom who's been through it already, who maybe was already a little reluctant, but then overcame her reluctance and went anyway and then benefited. That person probably has a lot more sway than all of us professionals.
yeah.
I mean, we could, it's hard because we care a lot and we want these moms to get help. And then we're offering help and they're not interested. And I mean, there could be this fear of child protective services. If they are using substances, they would definitely have a fear of child protective services. But that doesn't, we don't, I mean, I'm
Mm.
not saying they should, but I think they just, well, the goal is to help the moms. The goal is not to frighten them. Um, uh,
Karen, one of our participants, Karen, had a great comment too. She said, just kind of continuing the conversation and normalizing depression. You never know where it can go down the line, certainly. So just staying engaged. Michelle brings up a point too, that maybe there's, that a lot of our patients have multiple social determinants of health challenges. So it may just not be one barrier, but helping them think through a variety of them as well.
Yeah, and those are excellent points. Yes, absolutely agree with both of them. It's really hard. Um, yeah, because there's the external, the social determinants of health, there's the internal, the depression and how the person is thinking and talking to themselves. And then there's just, the particular relationships in the clinic and what other relationships that are important to them. They could have somebody outside, in their families. A real, there are plenty of people are like, don't go to a therapist. Bad things will happen. Um, yeah, just I agree with the person who said continuing the conversation. All we can do is our part, and it's hard to have such a small part. But if we can just stay consistently supportive and compassionate at every turn, it, don't underestimate that, your one interaction of support and compassion can really help, even though you'll never get that feedback that, oh, that, I mean, because you don't know, and you won't get the feedback just because you can't be like, the fly on the wall, in somebody, you can't follow them around and know everything. But being compassionate, I mean, there's a ton of research on how compassion is so powerful medically, psychologically, in every way. There's financially, it saves money. So there's a ton of research about compassion. So, just keep at it. But that is the reality that a lot of times you try and try and try again, and you just don't feel like you're getting anywhere, but you don't know that you're not getting anywhere. You're just not getting as far as you would like. You don't have the concrete evidence that you're getting as far as you like. All right. Those are great questions and comments. Any others, Dr. Bowling?
There was one other question that someone had, and we're running about 5 minutes left on time here. But there was one other question that Sarah Revis had. With none to minimal depression severity scores, when do you suggest that you rescreen for follow-up? How soon is it recommended?
Huh. That's a good question. I don't have an absolute when. I mean, but you well, with any change, you would always rescreen if say you just saw them the next day and they're like, well, I'm not feeling happy today. I mean, you can always rescreen sooner when they give you a reason to rescreen. Otherwise, it's probably just going to be based on when are you going to see them again. If you see them every week, you're not going to rescreen every week, but you're having some sort of check-in. If it's a medical appointment, it would be like monthly or every 2 weeks. I guess I would rescreen maybe monthly, or if there was a reason I thought I needed to rescreen. And you can always just give the 2 quick questions. I'm going back to, the first step, the 2 questions, you could do those more frequently. And then if these are ever positive, then you do the bigger screening. But if you're used to using the Edinburgh, and you want to just keep using the Edinburgh, then I would say monthly. But I haven't seen any clear recommendation about that. So that's just kind of off the top of my head. You don't want to screen too much, but not too little. Anything else?
Gabriel, Alexander had some great ideas. If you ever gets a chance to read in the chat box of some things that Gabriel put in there about things that you can do as well, just some ways to stay engaged. And Dr. Lazaron said in there too that she usually screens every 2 weeks also, which you like just like what you're saying.
Okay, that's good to know. Yeah.
Mark, did you want to wrap us up here?
Here I did. Well, let me just show real fast.
Oh, absolutely.
So it's 13% of the women have postpartum depression. Children are affected in all of these ways. And screening reduces depression at 9 months, and treatment reduces, it has, people do better with treatment after, definitely when it's measured a year. So I just wanted to put the last 3 questions up. So yeah, Mark can wrap us up. Thank you very much.
Thank you, Liza. That was a great discussion.
Yeah, thank you, Dr. Halloran. That was a awesome informational discussion we had today. Some people were asking about what comes next, so I will be sending an email with the video recording of today's presentation as well as PowerPoint slides. And Dr. Halloran did mention a resource that is coming also with some of this information condensed into a 1-page resource that you can use in your offices or with your patients. I'll just mention real quickly that we do have webinars coming up in this series as well, with some interesting topics about newborn screening, some diabetes discussion, ADHD, and then anxiety. I'll provide this QR code or the link in my email as well to sign up for those. So we look forward to having you at those as well. If you have any questions for me about today's presentation or the upcoming presentations, feel free to reach out to me by email. Otherwise, once again, we want to thank Dr. Halloran for a great presentation and hope that you all have a wonderful rest of your day.